Some people didn't hear that. Basically, bring you right down. Post-pandemic. The extraordinary levels of anxiety and depression, suicide statistics, and most urgently that help is in short supply, whether it be a generic mental health professional or a child psychiatrist. And there's data to back that in most counties in the United States. So even pre-pandemic, 2/3 of US counties had a shortage of mental health professionals. And if you use the HPSA, the Health Professional Shortage Area Designation, if you lived in one of these counties, which is the majority of counties, it turns out, it's associated with significant increases in youth suicide rate, especially by firemen. And as you might expect, these counties had very strong associations with sort of the usual culprits when it comes to social determinants of health: poverty, housing security, food security, you name it. And of course, their conclusion is, number one, there's not enough time to train the needed workforce of mental health professionals. And number two, quote, we've never valued mental health the way we do physical health, end quote. And they point out the challenges of attracting people to fields from primary care through the mental health fields because of lower pay and the issues about the challenge of training them. Now, we may hear something good when we hear some of the blueprint part of the presentation today about the fact that even though the mental health workforce is overtaxed, understaffed, et cetera, we may be able to still pull something off in a very good way. So I sort of looked at that and thought of the Neil Young song, but in contradistinction to that is really the work of this council. And if you think about it, we've had a really formidable charge from the start. We've had to persevere through a pandemic. We've had a fairly short timeline, even though I'm sure when the legislature set the timeline, it seemed luxurious. And we have a population that, at least when I'm at the podium, I'm always talking about, and I know Allison and others in mental health are always talking about, the fact that the population's in the thralls of a mental health and substance use disorder crisis. And we're not telling you that, they're telling us that. And we've had to learn that this is not a one-size-fits-all proposition, as evidenced by the abundant approaches and models that we've evaluated over the last year to year and a half. And then I think I may have quoted this, but we've had to listen to the kind of rhetoric that the National Academies of Science and Engineering and Medicine have espoused when they were talking about things like the whole health model. And they say the magnitude of change needed to accomplish whole health care implementation is great and will be a decades-long process. They also say this tall task will take seismic cultural, structural, and process transformation. That took the wind out of my sails, but I didn't want to give up. And actually, I think getting back to my optimism theme, there's really tremendous reason why, even with that kind of harsh language and almost hopeless sounding language, even though I don't think they meant it that way, we have a fighting chance to really do something good here in Vermont. Because if we look at this group that has been mostly linked by technology and not by in-person meetings, and has had large group meetings, small group meetings, broken into working groups, etc. I've seen nothing but positivity and really significant reserve energy. I think we've developed a cohesive working group at the mega level and very cohesive small groups that have made a ton of recommendations as evidence of the work that they've all been doing very deliberately over time. Certainly thanks to Kathy for structuring us in a way to make that work happen and make us have deliverables on a timeline. And the groups have embraced the mission, contributed to vibrant discussion, engaged on a whole host of topics and models for integration, and been, I think, very open-minded regarding the fact that there are diverse pathways to mental health integration. People have had to actively adult learning problem solve and show very realistic knowledge about the time that it will take, and never be as hopeless as the National Academy's statements make it sound. And I think we find, and we will find today, that we've built very durable relationships and demonstrated a great spirit of collaboration. So now we have a lot to wrap up because we wrap up in July. And this is May 9th. So we're going to continue all that work today and bring us closer to this ability to wrap up and really come up with some, I think, powerful and important recommendations. Today, we're going to try, once again, to get the notion and role of peers right, understand their place in all of this, in mental health integration. The notion of patient-centered medical home models, like FQHCs and the Blueprint Health Home. Community health workers, the expansion included in the governor's budget and to be appropriated by the legislature of the whole Blueprint enterprise. Their role in primary care, substance use disorder screening and intervention, caring for the vast majority of Vermonters who may have problems in the mental health arena that are amenable to identification and management as part of what I would call general medical care, with the focus on before they escalate to a crisis, since so much of mental health is viewed in the media and by the public, and probably by most of us as in crisis. But we have the majority of the population who say they are having mental health problems, but they are far from a crisis at this point. But they need the support that a mental health integration model can provide. And then there'll be more on the whole health model, and we'll learn more from the VA, learn more about co-located models, community mental health centers, and this whole focus that we have had to date and that grant money is providing us with the CCBHC initiatives. I think I said it all right. You never know. That's just in the next 3 hours. So I'm going to shut up because we have a lot of work to do and turn it over to Allison. And then we'll get through the really ambitious agenda that we set out for the morning.
Thank you, Dr. Levine. Good morning, everyone. Awesome to see you in person. So I did want to talk a little bit about when I think of wrapping up and how much anxiety that gave me for what I would have to tell the legislature to sort of name what we've accomplished. And again, like Dr. Levine, I want to give a lot of credit to Kathy and her thought partner, Mo, who I think in the very beginning those of us who like a direction or at least want to know what our tasks are, Julie Parker, that's good detail. And people who are trying to figure out what, sort of format and where we're going. This was really hard. I think there was a decision made early on, which took me a while to wrap my head around, that we weren't just going to embrace a model and top down it. And so then what were we going to do? And I feel like the one thing that's clear to me is I knew a lot of your faces and some of your titles, but the reality was, for most, I will be completely honest, I definitely didn't know what you did. And I certainly didn't know the scope of your work and the way that you could leverage certain pieces of our work. I still have a lot of work to do there, but it's incredible how much more I know now. And I credit that to the breakout rooms, where then I could sit and have a conversation with 3 or 4 of you and find out how much our work overlapped. And I think where I feel like we are now is, without going top down and without trying to do the sort of Western thing of let's have an expert come in and tell us what to do, and then we march forward, we're doing it a little bit more with tentacles going outward, I would say. And I think it was Logan who said in one of our meetings, where's spiritual transformation that needs to happen to get here? And I think we've used the words culture change, but spiritual transformation stuck with me because it feels like in the healthcare services and the mental health services, you're not just providing a service. People aren't coming in and getting the same thing from you. Actually, they're walking in the doors. Most of them, at least in the mental health world, are looking for some kind of transformation. They're here, they want to get to here. Or they want to identify what their health goal is. And that's a different way of providing a service than I think just making sure we have staff who can go in and do a rote task. And so when I think of all of us trying to do that, and I think of the barriers for someone trying to reach a health goal and somebody's suffering from anxiety or depression, and how helpless you can feel as a provider when you can't get the patient help the patient get where they need to be because you're not sure how to address that mental health issue. And so we automatically go to, well, let's have a referral to somebody else. And so this whole idea of, okay, how do we all build that competency to at least provide some holistic care is a huge transformation. And I think what's helped us through the pandemic is that, at least from what I've seen, and there's actually some data to back this up, that acceptance and awareness and reduction of stigma has happened for mental health. And it's happened because we all got anxious. Once you looked around and you realized, oh, in fact, there was some data showing in the beginning, people who really suffered from anxiety felt a lot better at the beginning of the pandemic because they were like, I was right. Like, the world is scary and unpredictable, and you're all walking around like everything's fine, and it's not. And so they looked around and saw other people feeling that way and were like, oh, thank goodness. And it brought some relief. So with that, I think those people who didn't understand started to get a feeling of what it's like to live in that world. And that's a good thing. What it also did was drive up those people saying, hey, you know what? Maybe I will try to go see a therapist at a time where the amount of therapy and the ability to staff that has gone down. So that's created a pretty stark situation. And I think where that leaves me is to have more people who can be helpful on some sort of spectrum, regardless of what your license is. And so I think where I'll leave you with this is that if you ever had the experience of, for me, it's about a banister. I'll explain this. In my house, we have this really old banister, and it's been driving me crazy because we need to get a new banister. And so for the past couple of months, my husband and I have been looking for banisters. So now wherever I go, I notice people's banisters. And that's, of course, something that I never noticed in my life. And I'll go to houses and I'm like, oh, wow, that's a really nice banister. And you just see it everywhere. And that's how I feel now with this work with integration. Because I go to a meeting, for example, we're involved in the governor's challenge for suicide prevention for veteran status. And now every time I'm in a meeting, I'm thinking, oh, how are you doing with identifying veteran status? And also, are you knowing that that puts them at higher risk for suicide? And are you asking about that? when we're writing contracts, we just did two big ones, mobile crisis response and mental health urgent care. It wouldn't have been that long ago where we just said your contract is to provide mental health services. And now we're saying, hey, what are you going to be able to do for integrated co-occurring care for substance use? We're writing that into those contracts. And I think when I sit down and meet with folks, just yesterday, Laurel and I were meeting with Agency of Education. We haven't had a lot of conversations about education in this group, but in that conversation, we immediately started thinking, we were looking at data together and thought, oh, you know what, we could overlay your data over our data, and we could decide to use some of the same measures to measure childhood well-being. And those are all places where when I think of a spiritual cultural shift where you're just thinking that way instead of trying to get AOE to agree to say, you know, here's your 10 measures and we're all going to use them, that hasn't worked that well. But when you're in a space where there is an opportunity to gel around it, that seems to be where we've landed. So really, I want to thank all of you. I know most of you have been here like almost all of the time. And when you're not, I know that it's because you have a lot of other things going on. But this has been energizing and awesome. And so I really, really appreciate the time and energy. And I look forward to, I think the last thing I'll say is whatever we put down on paper is what we put down on paper. And I think it's going to be great. But there's a lot more to it than that. And so I hope y'all walk away with that foundation. And then I think what we're going to do next is, well, first, you want me to talk about what we're doing today, Kathy?
Yes, Dr. Levine gave us a bit of an idea of that. I'm wondering if we've got all our folks there, David and are on. Hello. And we're looking for Dr. Christina Shook and Dr. Ward. Also, there I see that it's on. So I think you could just go ahead and introduce our guests, and Andy is here. Do you want to come up here, Andy? Yeah, there's Dr. Shook. Before we do that, I neglected, I wanted to introduce Mo. Mo McKenna came all the way from Toronto. She's from Return on Energy Consulting, who has been my thought partner through this. This could not have happened without Mo's partnership. And she's driven all the way from Toronto to be here today. So I wanted to.
Oh, thank you. Okay, today we have with us Dr. David Kennard. Oh, David Kennard is a mental health peer for the Tampa VAMC, the Florida Primary Care Clinic. Thank you for joining us. We have Dr. Benjamin Lord. He's a clinical psychologist, peer supervisor, also at the Tampa VAMC at Florida Primary Care Clinic. Dr. Christina Shook. She is at the VA Center for Integrated Healthcare, a peer support and the PACT implementation lead. And then many of us know Dr. Andy Pomerantz. He's a former VA National Director of Integrated Care and now a council member. Thank you for being here.
May I interrupt? Can we move the chair and get you folks a little friendly here so that I can get Amy in this room? So, yeah.
Pardon me for interrupting, but I don't see my colleague, Dr. Lord, on yet. So I'm just going to message him quickly to see if he's able to join. He might have been with a patient and might be with us very shortly. I just wanted to let you know I don't see him on the list right this second.
Okay, thank you. Can you switch over a little more, Allison?
Nice. No more social distancing.
Yeah. It's so yesterday. Is everybody, is that what you're seeing now? It's weird. Okay, good. Thank you, Laurel.
We can jump right in. I know we're waiting on Dr. Ward, but I think some of these first questions, I think this group would be a great group to answer. So I'd love to start off by maybe Andy, I'll direct it to you. Since you're in front of me and I know you've been working for the VA, when did the VA start using peers and how did that come about?
I think the VA, going on memory since I haven't worked for the VA in almost 2 years, but the VA formally started its peer support program in mental health sometime around the late 2000, 2008, something like that. It was around the same time that integrated care was being mandated throughout the VA. Long story short, I think last I knew there were about 11 or 1,200 peers working across the system, mostly in mental health. Christina and David did the updates. But the move into primary care, the first experiment with that, that's the best I can say is experiment. Just another opportunity to learn something was in 2014. That's when we first started putting peers into primary care teams.
Christina and David, did you want to add anything to, your thoughts on how that went to the beginning and how it came about?
It's actually before my time in the VA, but I did start working for the Georgia Mental Health Consumer Network back in 2006 as a certified peer specialist. So
there are, Andy, your memory serves you very well because there are approximately 1,300 peer specialists in the VA right now, and they vary. So the way the VA does peer support work, peer specialists are certified, and
thank you for the Maverick leader of Browntown. My apology.
oh, that's okay. They're certified, and they must be in order to have that discipline within VA. And there are a couple of different ways that VA allows for that to happen, but the full performance level for peer specialists in VA is a GS9, and so it's a discipline within VHA, and has become very well respected. And they have a scope of practice and competencies, and they have to maintain continuing education. So VHA, I think, has really paved the way for a wonderful discipline to flourish within the Department of Veterans Affairs.
Thank you.
Looks like our
And there's Dr. Lord joining.
Welcome, Dr. Lord.
Hello, sorry for being tardy. Time runs differently down here in sunny Tampa, Florida. Isn't that right, Dave?
Absolutely.
Very nice to meet everybody. Thank you for having us. Dr. Shook, it's nice to see you as well.
We only missed the first question, so perfect time.
So the next question is the one that I traditionally get to ask about anything that we do, which is what is the evidence base for using peers? So maybe we could start with Dr. Shook, and I've got Andy here by my side as well.
Sure, yeah, I'd be happy to speak to that. The research evidence about the positive impacts of peer specialist services is still in the early stages of development, both inside and outside VHA. But overall, there is a very positive signal that there are benefits for individuals who receive peer support services as part of their treatment planning for mental health or substance use conditions. And what the research is showing us is that we're seeing improvements in mental health treatment engagement and treatment retention. So people are more likely to get involved with treatment that they need and then stay in treatment that they need when they work alongside a peer support staff member. We also see reduction in symptoms of mental health conditions. And so you'll see things like reduced severity of depression symptoms, reduced severity of PTSD and anxiety symptoms, improvements in rates of abstinence from various addictive substances. And there is a lot of research showing improvements in quality of life, satisfaction with care, satisfaction and joy in life. And all of those outcomes are broad. They're both within and outside of VA. And then when you look at some of the benefits that have been found specifically within VA, it gets even better. So we see a lot of increased hope, increased treatment engagement, both in primary care and in mental health settings. And so that means veterans are more likely to engage successfully in their healthcare and to attend appointments, partake in the treatment recommended by their clinical providers. We see reduced isolation and loneliness, reduced symptoms of mental health concerns, increased functioning and engagement with your social life and your community integration. So lots of really positive emerging outcomes with peer support.
Thank you. Does anybody else want to answer that before we move on to the next question?
If I can, I was gonna shut up, but I just make a little point, just to emphasize the importance of treatment engagement. You know, we're in an era, we've always been in an era where access to mental health care, specialized mental health care is difficult at best. And every individual who's referred for mental health care and does not show up, or comes one or two times and then doesn't come back, is a ding on access, because that person has taken up slots that could have been taken by 2, 3, 4 other people in need of care who don't get it because somebody who's not engaging is kind of using up the time. So just by improving the engagement makes a tremendous impact on access to care. That's always the argument with managers. Say, why should I hire this peer? It costs me money to do that. The bottom line improves. Access for patients improves. Everything. Stars shine.
I would agree. Well said.
Me too, I agree. I think it's great.
Well, one of the things we're working on right now in Vermont is around what is peer certification and potentially moving towards a peer certification model. I'm curious, from your experience and the work that you do, what are the criteria for someone to be a peer? And maybe while I have it, do you have a definition for a peer?
Dave, if you want to talk a little, I can talk about like the policy side, and you want to talk about what it takes to, you know, what your process was,
Sure.
and I'll just chime in.
Okay, no problem. Thank you for that. And it's good to be here today. Hopefully everybody can hear me. I'm on site for a homeless stand down. So, you know, a peer is someone who obviously is willing to self-identify as an individual in recovery from a mental health challenge and or substance use. So that's a big piece. And of course, to be trained to use that recovery story or journey in a strategic way to provide hope in the reality of recovery to others is probably the key pieces. And so as a peer, you face, we still live in a stigmatized society, oftentimes towards those with mental health. And so you've got to be able to face that. And the other part is, you know, as we work as peers, we're also facilitating our own recovery. And that again, so it's a dynamic, growing situation that we're continuing to learn new ways, new skills, new techniques to keep ourselves in recovery, and we get to share that. But we're helping, in particular in the VA, we're helping veterans. We're walking alongside of them. We don't walk in front or behind, but we walk alongside them to help create the lives of meaning and purpose that they're desiring. So a self-directed life. And in order to get to that place, obviously recovery is essential. And so that's what we do. You know, we obviously engagement and re-engagement into mental health treatment or substance use therapy is often key, but so is connecting, uh, social connections, connecting to the community in which they live, accessing resources that will promote recovery. And then within the VA itself, it's a cumbersome program. It's a yeah, it's a cumbersome bureaucracy that is oftentimes adversarial to the veteran as far as trying to access services, which can then create barriers. So one of the things that I know that I do on a regular basis is just help smooth that navigation through that system so that the veteran can access the needed services.
Thank you. That's really helpful. Go ahead. Chuck, you look like you're going to say something.
I was, but what I have to say is much more boring than what Dave said. And so I'm wondering, would it be helpful to know the criteria for the certification? Like how that is that also part of what you would like to know?
Yes, and I'm glad you brought it up because I loved his answer. So I forgot I even asked for that part, but I do think logistically nuts and bolts would be helpful.
Okay, because I don't want to rob how wonderful his answer was, because it's really the heart and soul of what peer support does. And some of this other stuff is much more boring. But very quickly, and I'll talk from VA. So there are state issued peer specialist certifications that are actively maintained based on state specific requirements. So for instance, like Vermont has their own state certification body. Oh, I'm sorry, I'm wrong. I'm looking at it right now. You do not have an approved state certification process. Sorry. I was looking at my list of all the states and I'm going through it and I got to Utah and then I'm like, yeah, so you're gonna have your own process. And then I got to Vermont and no. So there are state issued peer specialist certifications. You do not have one. Within VA, what they have done is they have said, we will choose which state certifications are acceptable, because there's all sorts of certificate programs that you can go to. There's only certain ones that meet the rigor that VA will approve. And then VA has also said, we will accept, historically they did this, they will accept a certificate from the Depression Bipolar Support Alliance peer support specialist course, and also from an organization called Recovery Innovations in an International certification program. So there were two kind of national certifications they would accept and then specific state certifications. And that's how they said, all right, you have one of these, you can come in as a peer specialist. And we require that you have 1 year of employment or volunteer work that meets this specialized experience requirement as a peer specialist. So 1 year or 2,000 hours of specialized experience in peer support service helping roles. They do sometimes allow education to qualify for that. And there's a whole process you can go through to make that determination as well. But in order to be actually hired and employed as a peer specialist, you have to obtain that peer specialist certification, because that's kind of the governing body that says, kind of like a clinician, a clinical provider has a license and they have to maintain that license. VA says, we need you to have this certification and the maintenance of that certification to be in this role.
Thank you. That's really helpful. That's kind of exactly the type of thing we're trying to work through right now.
And I can give you those names of those organizations if it would be helpful later. We can always email.
Thank you.
Yeah.
So is there an expectation this is a paid role? Or can a system be set up where you have a choice of being volunteer or paid? And if it is paid, how does that actually work in terms of funding for the role?
Well, within VA, peer specialists are paid permanent employees. So if you are someone with that certification, the expectation is that you're going to be hired and paid because you're in that specific position description. But there are numerous opportunities to provide peer support in a volunteer capacity throughout the system, and they do that. There are volunteers that are not paid and work within places like community living centers and work within some of the homeless outreach programs within VA as well. So usually I think it's a little harder, honestly, to get people to volunteer in an unpaid position during business hours, but it's definitely possible. I think you run the risk, then also of not necessarily having the requirement for a certification and knowing the scope and the competencies of the role, but it certainly does happen within VA, and those are members of our staff and our workforce, just unpaid.
It sounds a little like the development, looking at Will, who has this awesome hand. The development of peer recovery coaches in Vermont, where we never had a certification process. We had dedicated, committed people with lived experience who, of course, want to be involved in helping someone else who's in need. But then we developed an entire system and educational and training system, certification system, and ability to actually make this a life calling that you can earn a living at, as opposed to just feel wonderful about yourself, but not necessarily have any resources.
I'd be happy to speak to that for a moment.
Yeah, that would be great, because it's sort of a parallel, I see it as a parallel thing.
It definitely is. We demonstrated. So my name is Will Everly, he, him pronouns. I'm the executive director of the Vermont Association of Mental Health and Addiction Recovery. So we train and certify the entire workforce in Vermont of substance use disorder recovery coaches. And in a previous role, I ran a mental health drop-in center, which employed peer support for 6 years. And also initially started as a peer support specialist, and before that, a peer with lived experience. So happy to speak from many of these angles. So what we found is that anecdotally, peer support is a modality that has been life-saving and transformational for people. And when we're able to provide real support, both in terms of remuneration and ongoing educational and professional development opportunities, then that workforce is able to grow their career and their impact over time. One thing that I find to be helpful to think about in terms of what a definition of peer is I would hazard that many people in this room have a lived experience of having overcome trauma or significant adversity in their life. And peers are people who are willing to sort of be out about that and utilize their own experiences with resilience and skill development to then pay that forward to help other people kind of go through those circumstances. So people that are peers have an innate lived experience that is the essential function of the position that you can't train. You can train business acumen, which is an example that you can see over here. Going from being a high school dropout to someone with a master's degree, you can provide those educational opportunities, but you can't train the lived experience, which is the core essence of how this work is transformational and life-saving. We've seen around the country that there is not adequate wages typically associated with these positions, and Vermont has an opportunity to set a bar that is actually sustainable and supports a workforce to really flourish and have the impact that it could. And we have that pathway within the substance use disorder field with statewide certification and training program, and professional development to use as a playbook to really replicate on the mental health side quite easily.
Thanks for that corollary. I wonder if David could comment a little bit on, is there sort of ongoing training to keep certified? Like, how are you evaluated, if you will? How do you evaluate yourself and your role and the kind of competency you want to have?
Thank you for that question. That's great. There is, again, because I became certified as a peer specialist in the state of Georgia, that is the state through which I maintain my continuing education, which is 12 credits each calendar year. So I take advantage of, well, let's see, there's a multitude of different venues that I access. Most of them are virtual since COVID has come online. But we have an annual conference for peer specialists each year. We also have an annual conference for peer specialists that work in the primary care setting each year. So there are continuing education opportunities there. And then the MHIC, which is and I'm still new to the VA, only 4 years, but I understand that's more of a national sort of research arm, and they have throughout the year different continuing education opportunities that are specific for peers. And then, of course, oftentimes they're national through the New York State. That's been a great resource for me personally. And then there are some clearinghouses that offer continuing education for like social workers and mental health counselors that actually oftentimes dealing with ethics that pertains to what I do as a peer specialist. So there are plenty of opportunities for me at least, to do 12 credit hours each year. As a matter of fact, I'm usually in the 30 range because I'm always wanting to learn and grow as a peer specialist. Remembering from my perspective as a peer, my recovery is ongoing. I don't ever refer to myself as recovered. I'm on a recovery journey, and I now live a life of meaning and purpose. And I feel like I can assist others, or at least demonstrate the hope in the reality of recovery to others. But I'm still journeying in recovery myself as I create a self-directed life. So there are plenty of opportunities. And I just wanted to add this other piece. And I have 13 years working for the Georgia Mental Health Consumer Network as a director, developing and implementing programs with state and federal block grant money. I can tell you that in the state of Georgia, there are plenty of opportunities for peers to work in multiple settings, respite houses, double trouble in recovery, peer mentoring, all kinds of different. And the pay is, as was mentioned, is not probably adequate enough, but there's plenty of workers and there's plenty of opportunities. And what I loved about Georgia was that peer services were Medicaid and Medicare billable, which is not the case in all the states. But I know that helped propel the profession in that particular state.
I have a follow-up that this is something that I've always tried to think about ever since I moved away from working out in the field to having an administration job where you have to think a lot about money and convincing people to pay for things and convincing Medicaid to pay for things. When I listen to the peer involvement and the role of a peer, and I hear it as walking alongside someone, helping with recovery, which is a never ending process, or in mental health, you're never done self-actualizing. How do you know, or how would you describe to somebody when say, okay, the role, your peer journey is done. Like you came in, we decided peer, or you decided peer work would be really helpful for you. And now you're ready to discharge from this peer work. I think there's some concern, or at least I have the perception that there's some concern, like everyone could benefit from this for their whole life. So how do you manage that?
I'm happy to answer that because actually I had a situation a couple years ago where I was working with one of the psychologists with um, very similar to what Dr. Lord does. And we were working together actually with a particular veteran. And there was this particular veteran ultimately just didn't want to change. And if I, in my interaction with this particular veteran, tried to go down the road of recovery and helping to promote and show the idea of hope and that change was possible, that individual just basically would tell me on a very regular basis, all I want you to do is just listen to what I have to say. Well, after a while I had to just say it. I'm a change agent. I mean, that's what I'm about. I'm about changing. I'm about growing and moving into recovery. And I said, when you're ready for that, give me a call. And it literally had to just, that was the end because that individual just wasn't at the place. Again, we walk alongside. I'm not there to push from behind or pull from in front. And when you come to the end, when they're living the life that they want to live, when it's self-directed, when they're no longer being stymied by the symptoms or the addiction. Yeah, and that's how and I can't believe it's 17 years, but 17 years doing the work, that's when I kind of know my role is done with that particular individual.
Thank you.
Welcome.
I can also just from a kind of mental health integration into primary care perspective, one of the things that we've tried to do systematically when we've integrated into primary care is we've really tried not to say or prescribe a dose of peer support services. We recognize that although in mental health integration in primary care, our clinicians work in a brief treatment modality. The idea is, briefer services for more, right? Population-based care. That's how we make sure we have access. We really tried to not prescribe that for the peer support role because part of the beauty of peer support is that ability to kind of walk alongside someone at their own pace to help them engage more successfully in those services within primary care. And Andy can speak to this because it was really Andy's vision, I think, and his voice in my head that made sure that I told people that across the country as we were doing this, because we wanted to see how it would unfold. And I can honestly say we haven't had a problem with the notion of there's not enough access to peer support services in the settings that we're in. The peer support staff have naturally kind of followed the primary care model. They've naturally, I think, done a briefer duration of care because the population is appropriate for that. And the peer specialists have also said, when they're recognizing somebody has more severe, persistent, serious mental health concerns, the peer specialists are acutely aware of that and are helping them connect to the community-based resources or the more intensive levels of mental health care that they need to manage those more chronic and persistent conditions. So it's been a really lovely synergy with putting peer support staff in primary care, and it's not caused a problem with access or a problem with we're going to follow these patients for life with peer support.
Yes, and I'd just like to add, absolutely. I mean, the nice thing about working here in Tampa with the VA is that we have peer specialists in mental health itself, not necessarily because I work in primary care and we do I do warm handoffs all the time. In that, for those more longer type situations. And of course, as Dr. Shook and I'll just reiterate it, the idea of integrating a veteran into the community, helping to either create or at least further develop networks of support is critical. And so that's something I'm actively involved with, as are the other peer specialists that we have here in Tampa.
And often the peer support staff know more of the community-based resources than any of the providers. And so, they are able to be system navigators as well. So your busy PCPs who are sitting there with, not knowing what to do, and the nursing staff in primary care, not knowing how to connect their patients, the peer support staff are just masters at system navigation, access to community resources, and those types of things. So it really actually improves flow and improves access and helps to connect that web of all of these resources together to enhance the quality of like team-based care.
So just so I can be accurate, I'm hearing a couple things. I'm hearing that peer is not necessarily for everyone, although it may be for everyone, but at different times in that person's experience, we're making the peer connection more or less appropriate at a specific encounter. There's not a dose-response relationship that we should be looking for. But now, importantly, to connect us to a later part of our morning where we talk about our community health teams and the blueprint, am I hearing that peers are actually fulfilling a screening and brief assessment function? So, if mental health has not been part of the issue, there may still be a screening part of what the peers connecting will be that then allows them to direct people to the right resources or inform the clinician that there's something more here.
I would say no. Their
Okay.
role is not to perform like proms, any type of evidence-based screeners. They actually are recommended to not do that, especially within VA. They're not mini clinicians, and those roles of, your nursing staff that are typically giving those evidence-based screeners, they should stay the same. What I mean to say is that often a peer support staff will pick up intuitively in their talking and interacting with a veteran. They will pick up on things that a patient may just not disclose or say to nursing staff or physicians. And often that intuition of that lived experience, that they have a gut instinct that clinicians take, we work for years as clinicians to build that gut instinct, and peer support staff, often just have it. They've lived it, been there, done that. And because it's a peer relationship, often patients are just more willing to disclose things to a fellow peer than they might be to a clinician. And so what I mean to say is that they're not assessing formally, they're not screening formally, but they may be attuned to things that a clinician maybe isn't picking up on, or maybe the clinician's picking up on it and says something's going on, but the patient's not telling me. I'd love for them to have the opportunity to talk to someone, and they might disclose to that person. And then a peer is a fabulous systems navigator and a person that can access local resources and has that knowledge base oftentimes to connect and help a patient more successfully engage with the resources that are available to them, or the resources that are recommended as part of a clinical, a treatment plan.
Yeah, I just want to add one piece to that. It's very tempting, when we don't have enough staff to have peers. Well, maybe a peer could do the screening, maybe a peer could do this. As soon as they start doing things like that, they lose their status as peers. They are no longer a peer. They kind of, and I've seen this happen lots of times, they kind of become a little bit more, like me, a little more of a clinician, and they're no longer a peer. So it's a slippery slope.
Can you talk a little bit about how you found all these peers? And so when I think of, we know that there's a lot of people in Vermont who have lived experience who want to help. But when it comes to finding people who are ready for that type of role, and people who you could call upon and you brought them in and you could trust they deliver effective peer support services. Do you have an army of these folks? And how did you go about, seeking people who wanted the role? And, also like, what did it take to set up that infrastructure? Because, I feel like it must come in fits and starts. Maybe you have some and then you lose some. And so how did that go?
Andy, you might even be the best person to answer that question with your historical knowledge. I can speak to it, but I bet you have some knowledge that I don't have even.
Well, I don't know. I tried to give it all away when I left. I think that one of the great, as my colleague who was the national director for peer support that I worked with for years, used to say, nobody ever starts life as an adult dreaming of becoming a mental health peer support specialist. It's not something that people are on a career track, but they evolve into it. And what I used to do with a lot of when engaging facilities around building the program was there are people who are in your clinics now. They are veterans. They have suffered through major mental illness, something, who you probably could help become a peer as part of their, their aspiration to help other people, and find a role for them as part of their recovery. That's where you find your best peers. People who have been through the program, people who incorporate it as part of their recovery plan. And there is an ancient shortage of peer specialists. That's always an issue.
And just logistically, when it, if we're curious, how it works, but I heard David say he does a lot of work online. In this program, is there a peer always available? And is there somebody in the office always available, or is it more of a referral process? How does that work?
Dr. Lord, you want to hit that one?
Well, I think I'd be happy to hit that one. Although I will say, first of all, there's many different ways to skin a cat. There's different ways to connect peers with patients. The way we attempt to implement things, at least here at our facility in beautiful sunny Tampa, Florida, is we have our peer specialists, among other things, functioning in an integrated way with primary care, kind of the way that we have other mental health staff integrated with primary care. So this is a long-winded way of saying we have two peers at two different parts of our primary care office, and we try to have one available at any given time for a warm handoff, although that's not the only way that they get access to patients and patient care. We have different kind of pipelines and programs that prompt us to get patients in front of our peers. We have them available basically to do kind of walk-in services or to get warm handoffs from mental health staff or from primary care. Did I answer the question as I was talking? I forgot what it was.
I think so. Does anyone else want to add?
I was going to jump in and just share that to speak from a systems level, as Andy mentioned, the first pilot of this was done in 2015, and then Congress mandated in 2018 that we expand the program, and we have it in operation at 30 sites across VA. So we have two peer specialists in PACT, and in VA, PACT is a patient-aligned care team. It's, the medical home of VA and primary care. And so we have two peers in PACT at only 30 sites across the country. But Congress just mandated in December of this year that we now have 2 peer specialists in PACT at all VA medical centers across the country. And so to answer your question, yes, there will be 2 peer specialists available at all VAs across the country. It's going to be mandated. We're working to start the implementation of that. And we do try to align our practices as best we can. Our working model is access. That's what's most important. And so the idea is just like with community-based PCBH models, primary care behavioral health model is open access to mental health services, same day access. You can do that in a lot of ways. You can do it by being physically present in the clinic. You can do it by video telehealth. And the peer specialists align their practices oftentimes with that model. So when we put our 2 peer specialists in PACT, we're trying to align with that same day access model and make sure that they're available to take referrals same day as much as possible and when desired by the patient. But they definitely will follow up if same day access is not available. If they're with someone or working with a patient, they always try to follow up within a timely fashion as well. So they really tried to align themselves with that PCBH, primary care model.
I think we should switch to audience now for a sec. There was a question here first.
Hospital Association. I just wanted to emphasize I had not thought about the value in the care navigation piece, not only in terms of just the practical value of having someone there to help you, but also someone who has been through it and can give you a little bit of hope that you can actually navigate the bureaucracy. So thank you for bringing that up. I think that's helpful. The other thing I'm a little bit curious about is I can understand the boundary between you don't want the peer specialist to become clinical, but do you see a potential for a workforce pipeline there in terms of, having clear boundaries, but maybe peer specialists may want to work their way up to become providers, or does that seem not possible?
It happens all the time. We lose so many peer specialists to becoming clinicians, and it's like drives me bonkers because I keep losing my staff that I have to report to Congress on because they keep succeeding. No, we love it. We love that a lot of our peer support staff, this is a pathway to career exploration and development. Thankfully, we're still holding on to David here. We love him and adore him. But yes, many of our peer specialists go on to get their degrees and become social workers and licensed mental health counselors. And they go into clinical roles. It does happen, absolutely. And it's a beautiful thing. And I think they are becoming, thankfully, many of them stay within VA systems, so we don't lose them. But it often happens. It's a pipeline for more mental health services and providers within your state as well, which is a good thing.
So I would like to say something on this. So as I said, I can't believe I've been doing this now for 17 years, and I've had opportunities, to move up, I guess you would say, go to grad school and do all that and pursue mental health counseling. But to be honest with you, I don't want to lose the piece that I have. For a lot of us that are and have been doing peer work, it's a pay it forward sort of thing. And I know that is for me. I like to say I'm the guy that you never, ever, ever would have thought would be in recovery. I was the one who was strapped to a chair in a long-term mental health facility with acute and chronic schizophrenia that my family was told I'd never leave. My wife at the time was given a recommendation to pursue divorce because I wouldn't be coming out. And it just so happened there were some doctors, psychiatrists, and a mental health nurse practitioner who years later saw something I didn't see. To quote uh, Dr. Patricia Deegan, it was the fragile flame of hope, and they saw it. And so for me, I don't want to do anything else but peer support because I get to pay it forward. And my fear has always been that if I got drawn over to the dark side of clinicians, no offense, just a little bit of humor, that I would lose that piece. And I didn't want to ever lose that opportunity to relate to somebody as a peer and to offer that hope uh, that there is recovery available for anybody if given the proper resources, motivation, all the things that are needed. It does take a village. It takes a lot of pieces together to bring somebody fully into recovery.
Thank you for that. That should be where we end this because that's such a high note, but there is one more question that I do want to invite in. So,
Thank you very much for joining us this morning. I was curious, as you have watched and been a part of the VA's transformation in terms of including peer specialists, how much definition there is in those mandates around the activities of peer specialists? Because I think for many of us, we see there's like an intrinsic value. We're not sure where those boundaries are. And I'm curious, as you, if you have thoughts for us as we're sort of thinking about system transformation, about how either specific or general or broad we should be in thinking about what is the role of peer specialists in the various parts of our community and healthcare system.
Dr. Lord and David, do you want to talk a little bit about the roles in primary care?
Dr. Lord?
Certainly, Dave, do you want to start just by talking a little bit about the specifics of what you do, and then I can talk a little bit conceptually, although that's a little bit more boring than the meat and potatoes, the day to day.
Well, as I said, pretty much every day I, look for opportunities to interact with veterans. We do have a thing that we started up 3 years ago here in Tampa, which I love, which to me falls very squarely within the skill set of a peer specialist. And that is that we, for veterans that are getting ready to come in and have their initial interactions with the PTSD clinic, we make a phone call prior to go over the details of the appointment. But more than anything, what we're doing is, at least I'm doing, is making sure that the veteran is ready, as ready as can be. So if there are barriers that get identified, and there often are, then we're using strategically, again, I like to use that term, parts of our recovery story, because most of us have been there at one time or another, um, to help them overcome their barriers to that appointment. Because what my experience has taught me is that those initial contacts, those initial engagements are some of the most frightful. And I do use that term for us. It's to be told that you have a potentially a chronic illness for the rest of your life, and times have changed. That's tough to hear. And when you can't see it, unlike cardiac or something going on with your heart or diabetes, where you can do a test and you can see it, getting better. This is here inside of us, and so it can be a challenge. So those phone calls really, Dr. Lord, I think for the first 2 years would consistently ask me if they were meaningful to me as a peer. I assured him almost every single time that they were, because it allowed me to engage with another individual who was standing at a precipice, I guess, if you would, or a juncture in the woods, that if went down and they decided to actively engage in treatment, could lead, along with some other pieces, to recovery, to having their life back. And oftentimes with veterans who experience PTSD, they can't imagine life ever being even somewhat normal again, especially those who've experienced combat. So to be able to tell them that that's a possibility, if they're willing to work, and that I'm going to be walking alongside of them, that can be very empowering. So that's one thing. The other part that I do, obviously, is because I work in primary care and there are a lot of interactions with veterans first time out, I am helping with system navigation, but I don't find that to be outside of my skill set at all. The VA is a large, complex system, and it can create inherently within itself barriers to care, which can then create frustration and anxiety, which then, of course, is detrimental to recovery. And so to help a veteran navigate a certain part of the VA, or at least lead them to resources that I know will be able to help them, that fits very well with what I do. And then the other piece, which is probably at least once or twice a week, is linking a veteran into the community with resources that are available. I mean, today I'm at a homeless event. I'm here, and part of why I'm here is to make connections with more community providers. Why? So that when I'm interacting with a veteran in a primary care setting and they're looking for a resource, I have personally vetted that resource. I know it's good. I know what they do, and I can share that with a veteran. So that's what I do. You know, have to do notes and charts, which is not my favorite thing. I have
Yeah.
to do that every day. Dr. Lord was probably hoping I wouldn't mention that, but we have that mundane part that has to be done. But by and large, being able to work in the VA and work with other veterans is really a wonderful opportunity for me.
Yeah, I
Thank
think
you so. Go ahead.
I don't have a lot to add to that other than I think the way we think about it here in Tampa is anytime a patient needs help engaging or not giving up on care, that is a ripe area for a peer support specialist. And they don't replace other mental health services. We don't try to use them to. Well, I think sometimes they try to get you, Dave, just to fill in system gaps that have nothing to do with you, and we push back against that. But
We do.
we've got mental health treatments that can be effective. They take a long time. They're frustrating. It's hard to go through, and they're only effective if people really not only engage, but also hang in there with us. And I think that's a big part of what Dave, you and Franklin do, is that engagement and then not losing hope across the process. So anytime that those are the questions, I think that is a place a peer specialist should be.
That was a great way of putting it. Thank you both. And I know there's going to be more questions, so I wanted to highlight that this group is going to be one of our breakouts for the stations later. So if you have further questions, hang on to them, and you'll get a chance to connect.
Thank you so much, everybody.
Thank you for the opportunity.
Sorry, Dave, what was that?
I said thank you for the opportunity of meeting with you as well.
So we will see Dr. Shook back later for our breakout. And so I'll just say, Dr. Lord and Dave, thank you so much for your time. We're going to take a break here now. So those of you online, also, we're going to take about, well, it's going to be a pretty short break. A little over 10, maybe 10 minutes. And then we're going to hear from the Blueprint for Health. So there's, sorry for those online, I feel like I'm being rude, but we have coffee and tea here. So we'll see everybody back here at 10:05. Thank you.